I love talking about lupus, so when I started to create this talk, it was about 5 hours long. So bear with me. I won't be 5 hours, I promise. But we'll try to keep it under an hour. So I know I was given a complicated title about ethnicity and Asian populations and lupus. You're going to hear some similar themes here today from what Dr. Peshkin has told you. So I've called this the 1,000 Faces of Childhood Onset Systemic Lupus Erythematosus. Again, another big mouthful. So we call lupus the disease of 1,000 faces. I'm sure all of you have heard of that, because if you lined up 1,000 people who have lupus, it can look like 1,000 different diseases, because not everyone is the same, and it's such a heterogeneous disease. So I do have a couple objectives today. I wanted to tell you a little bit about childhood onset lupus and what might be different between childhood onset lupus and adult onset lupus. It is the same disease. It's a continuum of a disease, but some things are very different in children than they are in adults. I want to talk about ethnicity because it is important, and I always feel like we're doing ethnic profiling, which everyone says is bad, but it's really important to do that when you're faced with someone who has lupus, because it's really important to be able to tell that family and tell that patient what you might expect so that you can treat appropriately. And then I also want to talk about what it means to have childhood onset lupus once you get to be an adult, because it's a little different. So many of you may have seen this complicated picture. You can find it on the internet. This is just to remind you that lupus can affect every organ in the body. And some of those organs we can see, and some of them we can't see. So everything from the brain to the lungs, to the kidney, to the GI tract, to the skin. Of course, we see lots of blood issues. And we see all these proteins or antibodies that you may hear about all the time. So that's why we call it the disease of 1,000 faces. So a more simplified view is the immune system. What is the immune system? These are our fighters. Call them soldiers, call them police, call them whatever you want. And these fighters see something like an infection. And that's what they're supposed to do. And they get all excited. They see an infection. They fight the infection. That's our immune system. We can't see the immune system. It's all those blood cells you have. In lupus, though, our immune system gets a little confused. And what happens is it sees ourself, sees our own body, our own organs, as that foreign infection and starts to fight that. And that's why you get all those symptoms: rashes, swollen joints, kidney problems, brain problems. So this is a more complicated view of what the immune system actually looks like. And it's all these different kinds of cells that are working together. And I'm not going to go through what these are, but just understand that it's quite complicated. So why do some people get lupus and others don't? In 2018, we don't have the answer to this question. We have some of the pieces. But as Christine alluded to, there's a lot more pieces that we don't have yet. And there's many reasons. So there's the lupus. So we have genes. I think genetics is all over the place now. You hear about genetics. You can take a little swab in your cheek and send it in the mail, and someone will tell you what your million genes look like. There's the immune system and why it gets all confused. There's probably a hormonal effect. If you look around the room, you look at any population of lupus, 80% of those people are female. It's not by coincidence. There's the world. So what other environmental effects? Smoking, pollution, all those kinds of environmental effects do affect lupus, as well as where you live in the world and the stresses that you face. The sun. The sun is really important. We can't forget the sun. Okay, you live in Calgary, you may not have quite as much sun as they do in Winnipeg or in Toronto, but it's still important. You still need to protect yourself from the sun, even in the winter, because that sun hitting the snow is actually much worse than the sun in the summer. So don't go to a tanning salon. And then, of course, those infectious bugs, those microbes. So oftentimes when someone develops lupus, something set it off. And often it's an infection, but it doesn't mean it's an infectious disease, but it's something that set it off. And then, of course, the big question mark, we don't know. Okay, so I like to frame this around a person, a patient, because that makes much more sense. So let's call this girl Sarah, and Sarah is 13, and she shows up with fever for 3 weeks. This may sound familiar to some of you. When her doctor saw her, she had large lymph nodes all over the place. She had this butterfly rash, which you probably can see here. The lighting's not perfect for that. She has a sore inside her mouth. She had low blood counts, what we call anemia. And she had all those proteins that you hear about, all these autoantibodies, ANA, double-stranded DNA, Smith, RNP, et cetera, et cetera. This is not difficult for us as the physician to say, wow, you have lupus. This is not a challenge, but oftentimes it is a challenge. But so what? So she has lupus, so what does that mean? Well, children are not little adults, and us pediatricians, we say this all the time, because there are some big differences between children and adults. And although most people who develop lupus develop it as an adult, 15 to 20% starts as a child. And here in Canada, we define child as under 18, but it really depends on your healthcare system. In the UK, they take care of children up to age 14 or even 12 in some places. Some other places are 16, some are 18, some are 20. It's an arbitrary line, but let's just say 18 for this point. So in children, the prevalence of lupus is about 1 in 10,000. So 1 in every 10,000 people in Canada has lupus, who's a child. Again, about 80% of those people are female. But the young people, the young children, under 10, it's about 3 to 1 or 2 to 1. So there are many more young boys in the proportion. But as it gets older, as you get past puberty, it's much more female to male. And if you look at the pediatric cohorts of the pediatric clinics in Canada, the average age of onset, if you're going to develop lupus as a child, the average age is around 13. It's about 12 and a half. And that will depend on who you're seeing. So in the UK, if they're only seeing kids up to 14, their average age of onset is going to be much younger. So children are different. So we know from studies done in Canada, in the United States, and actually around the world, that the children who present with lupus have more severe disease on the whole than the adults who present with lupus. More kidney disease, more brain disease, more important organ manifestations. They also have more damage early on. So damage is this thing that some things happen that can't really change, can't be reversed. So you develop a cataract in your eye, that's damage. We can't take that cataract away. We can take it out, but we can't get rid of it. You develop problems in a bone, avascular necrosis or something like that. We can't make that go away. You develop a crush fracture in your spine, we can't make that go away. So those are damage. You develop kidney failure. We can't make the kidney failure go away. We may be able to treat things. You want to avoid damage, and that's the point of everything that we do, is to avoid that long-term damage. So children are growing, right? So there's all those issues with growth, puberty, final adult height, that we have to think about, that are important when we're thinking about what treatments to do and to give. So if you think about a child who's 8 or 9, and they hopefully have another 90 years to live, that's a long time to have lupus, because in 2018, we don't have a cure. You know, we may be talking differently in 10 years or 20 years, but right now we don't have a cure. We want to control the disease for forever. But 90 years of disease is much different than someone who develops lupus at age 40 or 45 or 50, because the burden is going to be much less. Puberty, which I spoke about a little bit, and then all the psychosocial issues. Think back to when you were a teenager. Think about being a teenager. It's hard enough being a teenager and getting up and going to school every day and dealing with your friends. But imagine doing that with, 17 pills a day or 25 pills a day or 3 different medications and multiple hospital visits and multiple doctor's visits. So Dr. Peshkin showed you classification criteria. We use these because we are not able to today say this person has lupus, this person doesn't, this person does, this person doesn't, without using some of this information. I don't expect you to remember all these, that's not the point. Just to know that there's many different features or clinical things that we see in people who have lupus. I put in a bunch of photos just to remind everyone that these are some of the common things we see. So most children who develop lupus will have some rash at some point, but not always at the start. This is that typical butterfly rash, although this girl, it doesn't actually cross what we call the nasolabial bridge, so the bridge of the nose, but it has that typical rash. And remember, this rash does not leave a scar, but tell a teenager that when they walk into your office that, oh yeah, you can go to school tomorrow, it's okay, it's not gonna leave a scar, but boy, they're not happy about that. So this is a boy who has lupus, it just looks a little different. Remember, the rash can be on the ears. This girl, it does cross the nose. This boy, it's all over the face, right? So the rash can be localized or it can be generalized. And this is important when you're a teenager. Oops, I'm going the wrong direction. Okay, so there's all those other skin things. You can have sores in your mouth. You can have a rash, you know, everywhere. You can lose some hair. You can have a rash on different parts of the face, and this kind of rash is different than this. This kind of rash leaves scars. So, you know, that's important for many reasons. Children, adolescents, adults, nobody wants to have a scar on their face, so we have to try to prevent that. Raynaud's, sure, a lot of people know what Raynaud's is, when your fingers turn colors, when you go outside in the cold, or in the summer when you go swimming, or when the air conditioning's on in the summer. It's not just a winter thing. So the sun is a beautiful thing. I love this photo. I didn't take it, got it from the internet, but the sun is also not a beautiful thing when you have lupus. So it's really hard to tell that to a young child and an adolescent that if you go out in the sun, this is what could happen. Right? This is pretty significant rash. Luckily, this rash does not scar. And so this girl, you know, gets her medication and she's okay. But once that happens once, they're usually pretty good about putting sunscreen on. You don't want it to happen at all. Okay, so a lot of what I'm going to talk about, some of it is Canada-wide and some of it is localized to Ontario because that's where I am and that's where much of the research has been done. So in our lupus clinic, we follow at any one time between 200 and 250 children with lupus. So it's far fewer than what Dr. Peshkin would see, but it's still a very large cohort and is probably the largest, if not one of the largest, lupus clinics in the world, and certainly in North America. So in Ontario, it's a very multi-ethnic population. So this is from the census done in 2016, the general census. This is not lupus. And in Ontario, 30% of the population was South Asian. Sorry, 30% of the visible minorities. Let me go back. So Ontario is about 13 million, a little less than 13 million. And the largest group or ethnic group considers themselves white, so that's usually European descent. But there's a low proportion of Aboriginal, then it was called Aboriginal, Indigenous population, less than 3% in Ontario. But 29% of the population, almost 4 million people, identify themselves as a visible minority. So in the census, you've probably all filled out those forms. It's what you identify yourself as. It's not done by genetics. And in the greater Toronto area, 3 million people out of the 6 million or so in the GTA identify themselves as a visible minority. So we have a large minority population that we're drawing from. And within Ontario, of that minority population, about 20% is Chinese, 30% are South Asian, so India, Pakistan, Bangladesh, Sri Lanka, 16% Black, 8% Filipinos. There's a very large Filipino population now, and then other Southeast Asian populations, as well as Korea, Japan, etc. So we have a lot of non-white ethnicity. And then a number of years ago, so this has actually changed, but a number of years ago, we looked at the population in the lupus clinic, and we found it was about 38% white, a quarter Asian. And when I say Asian here, I mean predominantly Chinese, Filipino, Korean, Vietnamese, Japanese. There's not a very large Japanese population, at least there wasn't then in Toronto. 19% was Black, so about 20% Black, and 17% South Asian. So over the last several years, there's been a very large immigration from Asia and South Asia, and so the population in our clinic has started to change. So Dr. Linda Haraki, who's another lupus researcher who works in Toronto, this was a number of years ago. She looked at the population in our lupus clinic and wanted to compare it to what the population of Toronto looks like, to see if we're seeing what we should be seeing in Toronto or if it looks different. So I didn't pick pink and blue purposely, boys and girls. It's just the blue bars here are what we see in Toronto. So in Toronto, just under 60% at that time of Toronto considered themselves white or Caucasian. However, in our lupus clinic, about 35% or 34% were white. So we had a smaller population, proportional, of white patients versus non-white patients. So as you can see here, the pink bars are larger than the blue bars in all the other ethnicities. Meaning, you know, that we know this, but we just showed that we knew this, that our lupus population is more non-white than white and doesn't reflect the population in Toronto. So then if we move forward a few years, I'm happy that Christine told you all about the 1,000 Faces of Lupus project and what people filled out, those papers, et cetera. And we did this in children as well. We recruited, at that point, only from 4 centers across Canada. And if we looked, this doesn't represent every lupus patient across Canada, every child, but a proportion of them. Again, about a third was white, 32% Asian. Oh, I lost my number here. I guess it was about 20% South Asian, 17%. Smaller proportion was Black. And then we had some other ethnicities represented, Latino, Hispanic, and the indigenous population. But if we looked at the different centers, they didn't have the same number of patients that they entered. For instance, Halifax actually only entered 8 patients. So it looks really disproportional. So 6 of the patients were white and 2 were Aboriginal. In Toronto, we had the largest number of patients entered. And as you can see, it looks basically like our clinic. So a larger population of Asian and South Asian patients than there were of white patients, and a smaller population of Black, but we see probably there's a larger Black population in Toronto than there is in other cities in Canada. Montreal was fairly diverse, as well as Vancouver, although we know that Vancouver has a much larger Asian population than other non-white ethnicities. Okay. So what did we find? Well, I did some computer modeling where I took all the patients, I took their clinical features. So if we looked at that other list I showed you about rashes, renal disease, brain disease, et cetera, and I fed it into a computer because I didn't want to be biased, and I said, show me how they cluster out. And what we found was there really are 3 clusters of disease. You can have a severe disease, you can have a moderate disease, and you can have a mild disease. Makes sense, right? So what did we find? Well, about a third of the patients had this most severe disease, which meant they had kidney disease, they had low blood counts, low white blood cell counts, low platelet counts, low hemoglobin. They had arthritis, although only 40% had arthritis in that group. And then they had what we call mucocutaneous disease. So that's the skin manifestations, the ulcers, Raynaud's, et cetera. 40% fell into this moderate severity group. And of that group, they didn't have kidney disease. They had the blood manifestations that we have to treat, the low platelets, low hemoglobin, low white blood cells. Most of them had arthritis, joint inflammation, and most also had rashes and other mucocutaneous. And then if you looked at the mild group, it was only 25% of our patients that fell into that group. But of that, we called the mild group had arthritis and the mucocutaneous. And we call this mild because it's usually easier to manage that, to manage arthritis and the skin disease, than it is to manage the kidney disease. Now you can see that the brain disease doesn't fall in here anywhere because I think at the time that we did this, we didn't capture the kinds of symptoms or brain involvement that we would do now. We didn't have every manifestation written out, so I think we didn't capture it well enough. Okay, so this all makes sense, but what about by ethnicity? Did we see any differences? So what we saw was that, let's see here. If we looked at our Asian patients in this cohort across Canada, 51% fell into that most severe disease group. And that, again, is the group that had kidney disease, as well as everything else. 33% fell into the moderate group, so they didn't have kidney disease, and 16% into the mildest group. What else? If we looked at our Black patients, 41% fell into that severe group, had kidney disease, 50% into the moderate, and very few into the mild group. We looked at our white patients, and this really does mirror what Dr. Peshkin just showed us. 20% was in the severe group. So if you're white, you don't get kidney disease as often. You may still get it, but your chance of developing it is less. 43% in the moderate group and 37% of the white patients in the mildest group. Okay? So what does this tell us about Sarah? So Sarah is actually South Asian. Both her parents are from India. And she obviously has mucocutaneous disease. She has skin disease. She has an oral ulcer. Well, if we looked back at that particular study as well as other studies, we think her risk of developing kidney disease is about 50%. So that's a flip of the coin. So is that helpful to learn that information at the very beginning? You have a 50-50 chance of developing kidney disease. I think it is. I think families need to know this information. It's not me, I'm not able to say to her, you know, you have a 100% chance of developing kidney disease or you have a 0% chance of developing kidney disease. That's a much cleaner, that's much clearer information to tell a family, but at least I can give them some information based on what we know. And then her risk of developing brain disease is about 25%. Okay, so she feels better because we treat her rash. She's happy with the way she looks, but she comes back and now she has protein and blood in her urine. She can't see that, but we can see it under the microscope and with our urine tests. Her blood pressure is high. She doesn't feel that she has high blood pressure because often it doesn't give you symptoms. Her complements, those proteins in her blood, they're low, and she has some ankle swelling. So those are all signs of kidney disease. So she has developed kidney disease. Remember, when we think that someone has kidney disease, we really need to do a kidney biopsy because we need to see what the kidney looks like under the microscope. This is what we call a light microscopy view, and this is what we call immunofluorescence. This is all those proteins that we talk about and how they deposit or they aggregate in the kidney, and they help tell us what kind of kidney disease. Because this is what the pathologist deals with. There's all different kinds of kidney disease that you can have in lupus. A is not equal to B is not equal to C. Not everyone is the same. What we worry about is this thing that we call proliferative, or you may have heard of class 3 or class 4. That's the bad nephritis. That's the kind that can go on and develop kidney failure, where you need dialysis or a kidney transplant. We don't want that to happen, especially not in childhood. You don't want to be on dialysis ever, but especially not as a child. So that's why we do a biopsy, because we need to know. If you have one of these kinds, it's probably never going to cause you kidney failure. You may need some medicine for it. Same with this one, this class 5 thing. Probably never will develop kidney failure, but it's important to know what it is. Okay, so from everything that you heard earlier, plus a lot of the information that we know, a lot of the data that we have, what will determine Sarah's prognosis, how she will do? Well, she developed lupus before puberty. Well, actually, she developed lupus right around puberty, so may not affect. She's not white, so that makes it unfortunately worse. She has that bad nephritis, that proliferative nephritis. She has high blood pressure. We know that's a poorer prognostic feature. And she had a lot of protein in her urine, so that's one of the things. The other features that she doesn't have, she's not male. That has a worse prognosis. And you know, there's some other features. So what about kidney transplant? Is that the answer? I put this in because it's all over the news. Anyone know who this is? This is Selena Gomez. You're not teenagers like I deal with all the time, but you know, after this photo went up on Instagram, apparently she has the most Instagram followers in the world. You know, patients come in, well, I just want a kidney transplant. Well, this is Selena Gomez, who has lupus, and she got a kidney from her friend. And if you look through the internet, for anyone who's been on prednisone, you know what it does, right? You know the side effects of prednisone. You know it gives you this face, these cheeks that you don't like. This is the most Cushing order, the biggest cheeks that I could find on the internet. And this is a photo of her, I believe, just several weeks after her kidney transplant. She's obviously not gained weight from prednisone. This is not, in my opinion, this is not an advertisement or a good advertisement for how to take care of your lupus. You don't really want to have a transplant early in your 20s or as an adolescent. You want to keep those kidneys for 80 years because you're much better off with your own kidneys working. And so, yeah, I don't believe this is the right answer. Again, that's my opinion. I don't know if everyone agrees. Okay, so we give Sarah the treatments that we believe are the best, and she does feel better, but then she comes back several months later, and she's got sores on her hands and her feet, and she starts saying, you know, I'm really having trouble remembering things. I can't get to school, I'm sitting in class, and I have no idea what the teacher's talking about. I have this fog, I can't understand. she has headaches. You do some tests. We like to ask kids to subtract what are called serial sevens. So start at 100, subtract 7, and keep going. And they usually look at you like a deer in headlights. I don't know what you're talking about. They try. Many kids can do it, but sometimes they can't, and she couldn't do it. She wasn't having any hallucinations at that point, so she wasn't, when you ask questions, she wasn't seeing things that weren't there. She wasn't hearing things that weren't there. But, you know, when she read, the words were jumping out of the page at her. They were moving around. Maybe if she looked at the clock, she couldn't see the time properly. And she found that, you know, every kid wears headphones all the time now. She found that she had to turn the volume down on her headphones. So the loud noises were pretty bothersome to her. So this is what we call brain disease or neuropsychiatric lupus. You know, it often starts, when you develop it as a child, it often starts within the first year. So when we meet a new family, we say to them, you know, the first 2 years or 3 years are really, really important. If you're going to develop kidney disease, it's going to happen then. If you make it to the end of 2 years and your kidneys, there's been no problem, your chance of ever developing it is very small. So about 95% of everyone who's going to develop the kidney problem will develop it in the first 2 years, or even in the first 3 years, 95 to 97%. And that's children. I can't tell you all the adult literature because I don't know it as well. It's probably pretty similar though. Same thing for the brain. If you're going to get significant brain disease, it usually starts in the first 2 years or 3 years. So for Sarah, unfortunately, all these things happen in the first couple of years. So when we think about the brain disease, we're still in a big gray zone. We can do MRIs, and believe me, we do them. We do lots of blood tests, you know that. We do spinal tests, spinal fluid. We look at lumbar punctures. They can all be normal. And you can be hallucinating. And it's lupus. It's not that you have another disease, but you can have very significant brain symptoms and have normal tests. So you really need a good team working with you to try to figure out what's going on. Obviously, this interferes with your daily life. Know that there's a lot of different ways that a lupus can affect the brain and the nervous system. These are some of the ways. So this was also a number of years ago. Dr. Susan Bensler published this. She's a pediatric rheumatologist. She's actually here in Calgary now and has been for several years. And what you can see, if you remember back to what Venn diagrams are in math, the symptoms are often overlapping. So someone may have headaches, but they also have a mood problem. They may also have psychosis, so they may be hallucinating. They may have cognitive dysfunction or memory problems. They may have some movement problems or even a stroke or seizures. So what we see is that a lot of overlapping things. It's not usually just one distinct symptom. And so we have to treat that appropriately. So I have a very strong interest or a personal interest in cognitive dysfunction. So that's how we think, how we remember things, how we're able to process all the things that we do every day. So we know that cognitive dysfunction is different in adults than it is in children. And that's because the brain is maturing. And the brain actually keeps maturing, and you keep laying down new neurons until about 25. So it's actually through young adulthood. And that's why, if you remember, to being 19, 20, 21, even though you're an adult, you're really not an adult yet. You're really not always thinking rationally because you're still your brain is still developing. And unfortunately, this maturation period coincides with the onset of lupus for many people. So you have this double hit, and it can be a big problem. So this was a study I did a number of years ago when I worked in New York for a number of years. And you know, the ethnicity or the demographics there is a little different, or a lot different than here. And I was working in Washington Heights in New York, which is very Hispanic. Most patients there were either from the Dominican Republic, some from Puerto Rico originally, so Hispanic patients, and there was also an African American population there. I had very few white patients in my cohort, and that's really because of where I was in New York City. So I recruited a number of patients, about 50 of our childhood onset lupus patients, and those were all children, adolescents who did not complain of significant memory problems. So they weren't having, or they didn't feel they had significant cognition problems at the time. And we gave them a battery of what are called neuropsychiatric tests. So those are those, if you've ever done them online, or pencil and paper tests, like these IQ kinds of tests, and they take several hours to do. And you give many different tests because we're looking at different domains, different ways of how your brain is working. So everything from your short-term memory to your executive functioning, how you're going to get things done, visual spatial, so how you can do those puzzle tests, psychomotor speed, which is also the speed of how you respond to things. And what we found, so if you look at this graph, 0 is normal. So that's the average in the general population. Obviously below 0 may not be normal. Above 0 may be above the normal, above the average in the population. I think what you can appreciate is all 5 of these bars are below 0. So when we did the testing, all of the patients on average had some cognitive impairment. So then I recruited controls, because you always need to look and compare them to someone who's equivalent. This right now, the 0, the numbers, is comparing to the general population. And we know if we look at these kinds of tests, these neuropsychiatric tests or IQ tests, that the whole population does not perform equally, and that your socio-demographic background may change how you respond or how you do on these tests. And what we found was that the controls were also abnormal. The controls were also below 0. So in some ways, this was a little comforting. So these were friend controls. So we figure that friends are the same gender, the same age, and usually of the same socioeconomic background. So they're living in the same neighborhood, going to the same schools. So maybe this is a reflection of the New York City public school system. You're catching this online, right? But what we found is that depending how you define cognitive impairment, about 40% of our patients were abnormal, but so were 40% of our controls. So I kind of let this lie for a little while, and I'm not sure how we deal with this, but we know that people who have lupus report memory issues and brain fog and cognitive dysfunction, and we haven't found a good way to treat that yet, but it's still on the horizon. So then we think about mood issues. You think about teenagers, if you have any in your house or you were a teenager, mood is a big problem. And depression and anxiety are very prevalent in the general population as well as when you have lupus. So this was a study done by Dr. Andrea Knight, who is a pediatric rheumatologist who was working in Philadelphia. She just moved and joined our group in Toronto this month, so we're really excited to have her back. She's originally from Toronto. But she did this study where they looked at what is called administrative data, so the Medicaid population in the United States, which is the low-income population, and it's every ethnicity. And they found that of the people who had lupus, 19% had depression or depressive symptoms, compared to 4% of the general teenage population who didn't have lupus. So we saw more depression, we saw more anxiety, and other mental health issues in the people who have lupus, in adolescents who have lupus. Okay, so well, what else? So there's many reasons why you may have mood disorders as an adolescent. Lupus, you may have pain. You have stress of this chronic disease, stress of being an adolescent. There are genetic and heritable factors, although they may not be the #1 reason, but they certainly do play a role. There's the inflammation of lupus that may contribute to your mood disorder, your depression, your anxiety, but it may not be the only reason. So we have to think about all of these things, plus all the medicines that we give. The medicines themselves may give depression, or there's a reaction to having this chronic disease and taking all these medications. As well, this brain is under construction, right? This brain is still laying down neurons, and so there's many reasons. And this is a big thing that we deal with in our clinic every day, every week, how we deal with mood and mood disorders. And so we have a big team that helps adolescents to deal with their disease. And we're lucky enough to have adolescent medicine, which is a subspecialty of pediatrics. And they're able to come to our clinic and see all these teens to make sure that being a teenager is bad enough, but dealing with all the things that they're dealing with as well. I just wanted to segue just for a sec and say, that a big thing that affects quality of life is how many medications you have to take. And there's a lot of literature out there. There's a lot of information that says, well, you should be taking this medicine in addition to all your lupus medicines for your heart and for your bones and for this. We try to minimize as much as we can because we know if we give an adolescent one more medicine, there's one less that they're going to take, on average. And we know now from more and more of what's coming out that adherence is not great for any medication all of the time, in adults and in teenagers. And nobody wants to be taking medication. But we also know the number one reason for flare of lupus is not because the medicine's not working, it's because the medicine's not getting in. This is not being taken. So we have to be careful what we're doing as a healthcare team, and patients have to tell us. And so we try to be very open. And every day, every time I see a teenager, I always ask them openly, you just have to tell me how much you're missing and how much you're taking. Because if you tell me you're taking everything and you're flaring, then that's very different than if you're missing it a whole lot of the time and you're flaring. What we have to do is very different. I don't want to give you more medicine if you're not taking it. Okay, so I'm going to go back to that 1,000 Faces of Canadian Lupus study and talk about quality of life a little bit. So this is what we call a spidergram. You can understand probably why. It looks like a spider web. Unfortunately, the numbers don't really project as well, but you'll see them in a minute. So we give everyone who's in this study does a quality of life survey. And the one for the adults is called the SF36, and the one for children is called the CHQ. And it's basically the same survey. And it's several pages long, and it goes through all sorts of different domains of what affects your quality of life. Everything from your physical functioning to your emotional functioning. And this is all obviously subjective. It's what the patient feels, and there's multiple answers they can give. So there's multiple different domains, and what we have plotted here, so the outside is 100. So 100 is perfect, right? You have perfect, you feel that your quality of life is the best it could be in each of these domains. And the middle is 0. So we plot for each of the domains that we are able to evaluate, and the closer you are to the outside, the better you believe your quality of life is. So this blue blob is the quality of life for, this is the normative data for healthy children. This is a group of 400 healthy children, and this is what they look like. So you can see most domains are pretty close to 90 or 100. And then we plotted a bunch of patients with arthritis, juvenile arthritis. So they don't have lupus, they have childhood onset arthritis. And you can see that it looks a little different. So some of their domains, this is physical functioning, they don't feel that their physical functioning is the same as a healthy child, and that makes sense. They have arthritis, maybe they can't play soccer as many times a week as they want to, or maybe they can't play soccer at all. Maybe they have trouble getting up the stairs at school. And then we looked at our group with lupus, and what you can see is it's similar to juvenile arthritis, but in some domains, it's actually less. So quality of life is certainly an issue. We don't have one fix for this, but it was really important that we looked at this. So then we looked to see if quality of life differed by ethnicity. And I'm not going to show you every single ethnicity. I'm just going to show you the aggregate of white versus non-white. And I found this very interesting. So this is the non-white population. We included a couple other domains on here, but what's important still is to look at how close to the outside these domains are. And this is the non-white population, and this is the white population. So our patients who are white, this is self-reported quality of life, felt that their quality of life on the whole, and we do lots of statistical tests to see if these are significant, and many of these domains were. So on the whole, our patients who were white, who had lupus, felt that their quality of life was more impacted than those who were not white, of non-white ethnicity. Now, if you remember back, I showed you that patients who were white had less severe disease than patients who were non-white, of non-white ethnicity. So this is perception. This is your perception of your disease and how it affects your life. I'm not saying the good or bad, but it's interesting that it's a complete flip. So this has to do with all of your sociodemographics in your life and how you believe that lupus impacts on your life. Okay, this is New Year's Eve in Toronto at Nathan Phillips Square. I like to think of New Year's Eve as a time to think forward and think about the good things in life and all the things that are going to come and what's it going to look like from here on in. So I don't know how I'm doing for timing, but we'll see. This is a very complicated view. I tried to make it simple, but I realized I didn't make it simple. But Dr. Peshkin showed some of this information earlier. Survival with lupus has improved. So in the 1960s, survival of 5 years was 38%. That's not very good. 10-year survival was 25%. If we look to the 2000s, 5-year survival is now 99%, and 10-year survival is 97%. It's still not 100. I don't know how we'll get to 100, but that's certainly our goal. And then somewhere between the 1970s and the 1990s, survival didn't change a whole lot, but it certainly improved to 90 and 80. I think the difference between the mid-1990s and the early 2000s is we started to use our medications a little differently. We didn't really have new medications. We haven't had a lot of new medications, as you all know, but we've started to use them a little differently. So we really want to get to 100, but I don't know. So, you know, Sarah comes back and she wants to know, well, what does my future look like? Well, she's going to turn 18, and then I'm not going to follow her anymore. So I can't tell her necessarily what her future looks like because I don't know. Because we send them off to the adult world, and then there's all the people whose lupus starts as an adult that they get mixed in with, and maybe it's different. So I really want to know what happens to people whose lupus starts as a child. What happens when they're an adult? So I had this research idea, and I got a grant, and you know, Ontario is big. All the provinces are big, right? And unlike Manitoba, where you know everyone goes to Winnipeg in the middle, everyone comes to southern Ontario to be seen, to Toronto, to Ottawa, to London, to Hamilton. There's not much up here in terms of rheumatology service. There's some adult rheumatologists, but there's no pediatric rheumatologists. So I contacted all the rheumatologists and all the nephrologists around the province and all the hospitals, and I basically was a traveling roadshow for a while, and I went around to all these sites. I took about a year. I flew, I drove, I took the train, whatever, and I reviewed paper charts. I went through everyone's paper charts because a lot of people get referred to a rheumatologist that have maybe a positive ANA and some joint pain, but a lot of those people don't have lupus. And I didn't want to include people who didn't have lupus in our group, in what's called a cohort, so a big database of patients. And I reviewed a couple thousand charts, and I found 619 patients who definitely had lupus, who were diagnosed somewhere between 1984 and 2011. And what you do is you extract all this data, so you take all the data, all the clinical data, do they have kidney disease, do they have skin disease, et cetera, some of the medication information. You put that all in a database, and then you send it to this place called ICES, or ICES, not ISIS in the Middle East, the Institute for Clinical and Evaluative Sciences. And ICES has access to all of these databases, the OHIP database, which is the provincial healthcare database for Ontario, as well as many other databases that have information about every time you go and access healthcare. And then you de-identify it all. So you take out all the patient names, you take out all their identifying information. So it's all a jumble of non-identified data. And what did we find? So we had 619 patients. And so the average follow-up is about 14 years, which is longer than really any published study at this point for childhood onset lupus. But you can see that in the first, I divided these into eras because I think our treatments have changed over the eras. And if we looked at the first era, between 1984 and 1993, we have about 25 years of follow-up on that group of patients. The last era, obviously we're not going to have as much follow-up because it's only 2018 now. And so we have about 9 years there. But if you look at how many years of follow-up we have 8,800 or 8,800 years of observation. So that's a lot of observation in which to look at outcomes. 80-20 female male, pretty consistent. Age at diagnosis was just under 13, pretty consistent. Okay, so what did we find? Again, this is all of Ontario now, not just Toronto. And so it's a little more white, 44% white, and then 56% non-white. Again, this is tough stuff to talk about. We don't want to hear this, but this is the truth. This is what you need to know. So these are young adults. We think about Even someone who's 25 years out from their childhood onset disease, they're still in their 40s or early 40s. And if you look at the general population of young people, we would have expected 2 deaths in that 619, and so far we've seen 28. I don't know who these people are, so I can't tell you all of the information about why they died. We have some of that information, but only what we can get from hospital data. I can't go back and contact people or families to find out what happened. So what does that mean? It means we do something called a standardized mortality ratio. So that's comparing to the population of the same age, same gender, what we would expect. So 1.0 would be the mortality ratio for the general population of this age. And instead, if you have lupus, the standardized mortality ratio is 15. So like 15 times as likely to have mortality. And if we look at white versus non-white ethnicity, if you were not white, you were more likely, the non-white population had a higher mortality rate than the white population. Okay? And that would go back to the severity of disease. Everyone has access to healthcare, so we don't believe it's access to healthcare. But there's all those socio-demographics as well that are important. And recall that our indigenous population is actually quite small in this group. So it's non-white ethnicities, but not just an indigenous population versus non-indigenous. Okay, let's think about happy things. What about pregnancies and births? You know, these are teenagers, and both the girl and their mother, of course, they want to know, is she going to have a baby? Is she going to be able to have a baby? Not is she going to have a baby right now, but is she going to be able to have a baby? And, you know, I hope the answer is yes, if she wants one. So when we look at this population, we take out the females who are of what we call childbearing years or eligible. So I took 15 to 45, knowing that there aren't that many 45-year-old women who want to have a baby, and there aren't that many 15-year-old females who want to have a baby. But you try to keep it as a big a population as you can. And that gave us about 5,000 years of patient observation and a mean disease duration of 17 years or almost 18 years, which is pretty long. And what we found was those who did have a baby, their average age was 26.5 years old at the time of having a baby, which is a little younger than what we're seeing in the Canadian population right now. So in these 502 women, there were 230 pregnancies. So this is actually the largest number of pregnancies to be reported in this in childhood onset disease to date. There were 107 live births, so 47% of those pregnancies had a baby. There were 8 stillbirths, so 3% were stillbirths. So that's a higher number than what we would expect in the healthy population. 36% had abortions for whatever reason. Either they were told by their physician, or it was a decision made with the healthcare team, or they didn't want to have a child at that point. And there were 14% miscarriages, which is about what we would expect in the general population. So that didn't surprise us. It was this number that was higher than what we would expect. This was what we were most surprised by, though. So when we think of, you think of that 9 months of pregnancy, it's 40 weeks. 40 weeks of gestation. If the baby is born before 37 weeks, that's considered preterm or early. Having a baby at 36 weeks is really not usually a problem. Having a baby at 28 weeks is probably a problem. So a quarter of all the live births were delivered before 28 weeks. That's a very high number. So this really means that any young woman who wants to have a baby, who has lupus, really needs to be under the care of someone who has expertise in this realm. Because you don't want to have a baby at 28 weeks if you can avoid that. And you want to have the best care that you can have during that pregnancy in order to have the best outcome. So I'm getting there. I'm almost done. We'll see. What about kidney outcomes? So 42 patients out of this big group have developed end-stage kidney disease, needing dialysis, and 17 have had transplants. This sounds like a big number, but it's actually much lower than what's reported in the United States and what's reported in the literature out there. So I think we're doing better than the average for kidney disease. I wrote okay. Okay meaning you have your own kidneys and they're working. in somewhere between 80 to 93%, depending how you look at the data. And that is actually greater than what's reported in the literature. So I think that's a good thing. So this is my favorite bridge in Calgary. You can look at this bridge and you can say, wow, it looks really long, or it looks, depending on your perspective. Right? Why do I care? Well, what about Sarah? What's her life going to look like? Is it going to look really long? Is it not going to look really long? And that depends on your perspective. Well, she had kidney disease improved. She has trouble remembering to take her medications, like pretty much every teenager. But her current disease activity is low. That's great. And unfortunately, though, she's developed some damage. She developed a cataract. That's probably from all the prednisone we gave her, but she needed it in order to control her other disease. She's developed, her bones are low bone density. She doesn't have fractures, but she has to be careful over time. At one point, she didn't have a period for over a year, not because she was pregnant, but because she was sick, she had inflammation, and we were giving her lots of medication. She did get her periods back, though. And she did finish high school, and she's attending college. So, you know, for me, I want to know what happens years down the road, but I don't know that yet. Remember, I've really talked about a lot of this, but we like to think of adolescence as a developmental psychosis. Every child goes through it, but everyone has some issues, right? So there's all these things we have to think about during adolescence, in addition to having lupus. It's not that all those things go away. So we want to know no lupus. We're not there yet. So we like to have a team approach. We have the physicians in the clinic, but we're not the only people that are important, that's for sure. So we have the rheumatologists, the kidney doctors. We have our adolescent team. We work closely with our psychiatrists because they're really important, especially with psychosis and mood disorders. We have lots of other specialists that we send the kids to see when needed. The pediatrician or the family doctor are really important. Unfortunately, sometimes they feel like they're out of their realm and they have trouble because they're just not, they may have one person who they take care of who has lupus. And they often will defer to us because they're not sure. We have nurses in our clinic who are really, really important with ongoing care. We do have access to a social worker, a dietitian, peer groups. Peer groups are really important, but sometimes they're great and sometimes they're not great. Sometimes peers, especially adolescents, will tell each other what they should be doing and how they should be taking care of their disease. So sometimes that's an issue. But most of the time, to provide support, they're great. We have physiotherapy and occupational therapy, and then we also have to remember about school, right? And transition to adulthood and transition to university. Many of our children go on to university, but we have to help them get there and help them get the things that they need. So what are our goals for success? Well, early and accurate diagnosis. Look for your high-risk patients. We want to improve their quality of life by looking at everything that's going on, not just the medical piece, but everything else in their life. We want a therapeutic alliance. I want them to tell me if they're not able to take their medication. I don't want them to lie to me. We want to prevent flares and prevent damage. We treat with a lot of medication. We treat very aggressively because we want a long life. We need to manage and prevent infection because infection now is still a big problem. And people end up in hospital with bad infections because of their disease plus all the medications we give. Immunizations are important, and then other prevention is also important. So in summary, well, childhood onset lupus can look a little different than adult onset lupus. It's more prevalent, more frequent in people who are not white. Ethnicity is a predictor of severity and prognosis. It's not the only predictor, but it is definitely one predictor. Kidney and brain complications are unfortunately frequent in children and can be severe. And we think that overall survival in kidney disease from our preliminary data may be better in Ontario, and hopefully we can extrapolate that to all of Canada compared to what is currently known in the lupus populations from around the world. And I think our first data of pregnancy outcomes of women with childhood onset lupus do unfortunately show a high rate of stillbirth and preterm birth, but there are a large number of patients who are able to get pregnant and have live births, have children. So we hope there's a light at the end of this tunnel. Things are getting better. And I want to thank everyone. Thank you for your time, your patience, for listening. Mostly I want to thank all of my patients, or all of our patients, because without them, I couldn't do any of this work. And we wouldn't be able to make things better. So thank you.